Today's webinar is on topic ceramic restoration on anterior teeth. Myself, Dr. Sufiyan. I'm practicing in Kuwait. So I will take the lead and I'll start the webinar. Welcome everyone once again. And on the onset, I just want to refresh the memories. Few weeks back, I was in Ethiopia, Addis. We had a Ethiopian dental conference and global implant symposium. It was a wonderful arrangement from EDBA. Congratulations once again. Just yesterday, I was seeing the photographs in the Facebook, which was uploaded. It is as fresh memory as yesterday. So I got a chance to meet so many of you and roam around Addis a little. Hopefully to come back there soon. So a little about myself. I'm Dr. Sufiyan. I'm a prosthodontist and I have a diplomate in GCOI and ICOI mastership. I'm a faculty at the Cochin Implant Center. Many of you might be knowing Dr. Jebin. So I'm a faculty there and completed my integrated implantology from Germany, and I'm practicing in Kuwait as a private practitioner, and I follow both prosthodontics and implantology as well. So that's my wife. She's also a prosthodontist and implantologist. We practice in a center here. She looks after one center and I look after the other, both prostho and implants. And that's the center I work in. So just a little gratitude and thanks for the staff, which I'm working. My staff make my work much easier, and having a good staff and a good environment in clinic will help us in our long run. Yes, so today is a topic on ceramic restorations on anteriors. So what comes to your mind when you hear ceramic restorations in anterior? The chat box is open. We can type it. Yes. Anyone? So how did we come to this topic was Dr. Meron was coordinating with me. So saying that we were discussing and to come to a conclusion for a topic where it should help in a private practice for everyone. And ceramic restoration is one of the type of a treatment where we come across in day-to-day dentistry. So that's what we came to a point where we will go ahead with the ceramic restorations in anterior and later on the posteriors. So I'll be including basic veneer preparations, crown preparations, little bit on smile designing, and basically on materials and stepwise how to follow a crown and bridge dentistry and smile designing and veneer cases, be it impressions or the temporizations and materials and instruments used, and how do you set up your aesthetic practice, right? Yeah, I got few answers here. Crown and bridge ceramics, yes. Aesthetic issues, yes. So we as a dentist, we have the ability to change smile and bring back what the patient has lost. And smile is not just teeth; it constitutes of the lips, muscles, face, and whole orofacial region. And nowadays, it's aesthetic dentistry is come to a facial aesthetics also, and that's where aesthetic dentistry has emerged right now. And when I tell aesthetic dentistry or smile designing, it is nothing but enhancing the beauty of the face and the mouth. And this is our, when you see a good smile or a good face, you feel so much positive, right? So this is what it's all about. You see this picture, you might have come across this. Why smile is so valuable? It's a matter of joy, confidence, health, and having a peace of mind and a positive approach to a life, right? In today's world, people are image conscious, and everyone deserves a good smile and needs a smile makeover. So that's where this aesthetic dentistry is very important. You see here, the person here, the male, doesn't have an eyebrow, but our eyes goes to a lateral missing and the gummy smile of the female here, right? So that's how we dentists are trained. These are few beautiful photographs of Indian actresses, right? So imagine these without the teeth here, right? So teeth make us gives us beauty to the face, right? So I was coordinating with the EDPA CPD provider director here. So uh, we were just discussing a few celebrities from the Ethiopia. I came across Hele Gebrisele. I hope I'm uh, pronouncing it right. See this, I'll just point out here. See this lateral spacing here, you can see. And later, I think he got the fillings done and closed the space to have a smile, right? So the next, there are two look. I think she's a sports person, runner, I guess. So through this webinar, I got to know a little more of Ethiopia. I've seen her smile change, how it has come to this level, right? And I think this is Lydiana Solomon, I think. So she has brightened her veneers, which she had done. So this is before and after. As going through during the process of the webinar preparation, and this is a singer, Teddy Afro, right? So see his smile here and here. So smile designing is not only for the celebrities, and our patients also deserve this kind of a smile design, and anterior aesthetics is nothing but smile designing. And why don't we give them a good smile and give them a positive attitude towards the life, and make them feel like a celebrity, right? This is, I think this is one of the celebrities, also actress. I did not get the name right. And not just there, everywhere in the world, the celebrities look for smile designing, right? Even though they are celebrity, they want to enhance the smile, right? So indirect restorations give you a feeling of a celebrity, and that's what we are looking for in a long run, right? So imagine now you have a patient like this coming to you in your clinic, discolored central incisor or a broken central incisor, right? Or a cracked tooth like this with a discoloration and few discolorations here. So what options do we have? We have options of direct restorations and indirect restorations, right? How can you enhance this? I think there is some issue, just a minute. Yeah. So direct and indirect restorations. So direct restorations are nothing but fillings, what we do, that is composite restorations, resin composites and temporaries, which we do on the same appointment on the patient's. I think there is some issue with the screen. Okay. So once again, direct restorations are nothing but which we do on the same appointment on the patient then and there, and the indirect ones are nothing but we make the impressions, send back to the lab, get the restorations such as crown and bridges, add veneers, inlays, onlays. So those are indirect restorations that are lab made, right? So this is the composite restoration. This is the direct restoration which I was telling about. And this is the indirect restoration. So the aesthetics, durability, time, cost is the difference between the direct and indirect restoration. So basically, if the abnormality is slight, like you have to change the color or the contour of the tooth, you go ahead and do bleaching, cosmetic contouring of the tooth, composite fillings, right? And then direct restorations, right? Composites or diastema closures or post-endo fillings along with the aesthetic shades. So these are the direct restorations. What are the advantages of this? Same appointment, the treatment can be done. You can preserve the tooth. There is no tooth preparation needed. Satisfactory durability, right? And the technique sensitive, it is easy to place when compared to the ceramics. What are the disadvantages of this? Discoloration. Yes, over the period of time, the composites get discolored. Fracture resistance is less. Definitely, you cannot bite hard or chew very hard food substances on this tooth. And color matching aesthetic results is satisfactory when compared to the ceramic. So the drawbacks of this direct restorations are the advantages of indirect restorations, that is ceramic restorations in anterior teeth. This is what we are looking for in today's webinar, right? So ceramic restorations provide superior aesthetics. Biocompatibility is good with the tooth and the gingiva. Strength and durability is good, that is the long lasting restorations. Color stability is excellent. You can match exact shade to the adjacent tooth. Preparation is minimum. When you choose the lithium disilicate, I'll be telling you in a course of my talk. Precision and custom made to that particular patient, right? So what are the indications for these ceramic restorations? If I consider only the anteriors, you can see this post-endo filling, the post-endo filling here on the central incisor, or the old crowns, decayed tooth, cervical abrasions, right? So these are the indications. If you come across this kind of patient, these are the patients for your aesthetic smile makeover. Patient has diastema. If patient doesn't want to go for ortho treatment, we can close these diastema with the ceramic restorations, which are long lasting and minimum preparations, right? This is post ortho. You have the spaces here because of the shape of the tooth. The orthodontist couldn't close the space here, right? Because the tooth shape is like this. So in that situations, you can go ahead with closing these diastemas with the ceramic veneers, which is minimum preparated. Post endo tooth here preparations, crowding. The smile line is negative here. A treated tooth, fractured, old composite. So these are the cases where you can go ahead with ceramic restorations rather than zirconia and enhance the smile as well. Old composite veneers and replace them with the ceramic veneers, lithium disilicate. Old PFM crowns, you can remove and give the ceramic restorations. So what I could say is dentistry is all about aesthetics, right? So I just want to start this my slides and get to a little more deeper aspect of the subject. Let today be the start of something new. And once you finish this webinar, I'll be changing your perspective regarding the ceramic restorations and thinking in aesthetics and smile designing point of view. So the journey of A to B is going to be not be very easy. That's the treatment planning and the treatment navigation, what we could say. So there are so many protocols to be followed, so many tricks and tips you will learn, and I'll systematically break down and explain to you each step and each appointment. How do you go about? Okay. So any anterior case, smile assessment is the first step which you do. So what we can do, you can give a small paragraph and tell the patient to read it out. And during that process, go on clicking photographs so that you can see the incisal visibility and the kind of a smile. What I generally do, I give a paragraph to the patient to read, which has a kind of a joke or a comedy scene or something like that, so that will make the patient smile or laugh. And I keep on talking to the patient during this time also, so that the patient will give the maximum smile what he or she has. So imagine now in this slide, if the patient gives you this kind of a smile and you think this is the maximum smile of the patient and you do not see any gum here, you go ahead and give veneers or crowns to enhance the smile and change the shade, right? And then the patient smiles a little more after the veneer, and after the treatment she smiles a little like this. So what you can see, this patient has a gummy smile. This was not a case for smile designing straight away. You have to go ahead with the orthodontics intrude, or if the patient is not willing for ortho, do the veneer and do some lip fillers or facial aesthetics to enhance and close the gum visibility. So smile assessment photographs and videographs are very important. This is the first step. And after that, we have to know the principles of ceramic restorations, tooth preparations for veneers and crowns, where to place the finish lines, gingival retraction, how to do impression making, what are the materials used and what are the techniques, how to select the shade, temporization techniques, material selection, which material you will be using. No doubt it's about ceramic, but which kind of a ceramic? Ceramic CAD-CAM based or layering based or ceramic press. So which kind you need to, or it's a monolith or a multi-layered, you need to decide. And if you have to do a BIS trial or a coping to match the shade, you have to do this. Then comes the cementation and then checking the occlusion. What I feel, if we follow this step, I'll go ahead with preparation, finish line, retraction, impression making. Then I decide the materials. So I'll be doing some kind of an injustice to the patient, because imagine I have prepared the tooth around 1.2 millimeters overall, 360-degree. That is a tooth preparation. And then I decide to give a monolith crown, right? So monolith crown will not need 1.2 millimeters of preparation. So what am I doing? I'm sacrificing the enamel around the tooth. So what I feel through this webinar, I want to just emphasize that selecting the material before even starting the tooth preparation is what is very important. Select the material first, decide on whether you'll be giving monolith or a multi-layered or which kind of Emax or lithium disilicate you will use. And after that, you go ahead with the required tooth preparation, right? So I will choose the materials first and then go ahead with the rest of the process. So let's start this by learning a little more of materials. If I can divide the restorations into two, it will be in multi-layered or monolith kind of restoration. Multi-layered restoration is nothing but coping and a layering on top. But the monolith is nothing but whole block, whole crown or a veneer, or if you go posteriors, you are giving onlay or inlay or a crown, it will be in a complete only one block. Okay, whole block will be you will be cutting the lab will be milling the crown or veneer or restoration. If I can give you example with this kind of with a dessert like this is a kind of a monolith. The whole chocolate here, pastry cake, is nothing but a monolith, and the glaze on top for the ceramic for the shade. This is Black Forest with the layers. This is nothing but a multi-layered restoration. Coping will be inside, then a dentil layer and the ceramic, the enamel layer. Right? So let us go a little more detail in this. Multi-layered is nothing but porcelain fused to metal, porcelain fused to zirconia, or lithium disilicate. These are multi-layered restorations. Monolith restorations are metal crowns, zirconia crowns, lithium disilicate full contour, and veneers, feldspathic veneers. So Let's stick on to the ceramic restorations, where the ceramics will be into function. That is, if you are giving a zirconia as a base, as a coping, and on that you will layer with dentin ceramic and then a enamel ceramic. This is called a multi-layered restoration, right? So for a multi-layered restoration, you will need more tooth preparation. So that's why I need to decide on which material I'll be using for the crown or a veneer or a restoration. So advantages of this: good strength and aesthetics is moderate. Thinner sections, the strength is good because you have the zirconia as a core. It is done with the CAD/CAM technology, that is precision is very good, and multiple shades of zirconia are available. So imagine a tooth with a darker core, something like this, and you want to mask it. You can use this zirconia as a core and then layer it with a good ceramic on the top. Where is it indicated? Since it has a good strength, it can be used in crown, bridges, implant prosthesis. In thinner sections, the strength is good. That is the large restorations, post-endo fillings, post-endo restorations, you can use this. Since the precision is very good, you can use this in a compromised bonding surfaces. That is a large post-endo filling is present and you want to give a crown on top, you can go ahead with this. And if you have a darker shade inside or a metallic restoration such as post and core, cast post and core or metal post, you can go ahead with this zirconia coping with ceramic layer. The only advantage what I can think of is more tooth preparation. This is what I don't like. We are sacrificing tooth more. And since it is multi-layered, due to the occlusal interferences, if present, the ceramic might chip off, right? So how is it fabricated? Zirconia coping is done with a milling machine like this. It is milled and after that it is layered or it is pressed with this kind of a ingots. So that was about the monolith. Let's come to monolith zirconia, right? Zirconia is nothing but a full monolith is nothing but complete core and the full contour restoration will be of the zirconia. Okay, I'll not go much into detail of this because there is no ceramic on the top, only zirconia is being used for the restoration. How it is milled? It is milled with this kind of a blanks which has various shades like this. The smaller blanks for a single crowns, or if you want to have a bridge, you are having a bigger blanks like this, right? Indications, again, posterior teeth, compromised core structures, anterior not much use since the aesthetics is not that great. How is it manufactured? Again, the milling block is taken, whole restoration is milled in a single unit. That is a monolith. Then comes our important material, that is lithium disilicate. This is my favorite. I've been using this since many years now, and most of my restorations are lithium disilicate and ceramic. Very rarely I use zirconia restorations as a monolith, that too in the posteriors only. And this lithium disilicate is so versatile. It can be used as a monolith, it can be used as a multi-layered, right? And it can be used in a cutback situations. Okay, so monolith is nothing but, as I said, whole restoration is one unit, be it a veneer or a crown. Layered is nothing but a coping is there inside. Okay, and then on the top you will layer the ceramic. Cut back is nothing but almost 2/3 of the crown is monolith, and on top only the incisal translucency or incisal anatomy you want to get, only that will be layered. This is a cutback. Why you want to know all these things? Because when you write on a job order for a patient, you have to write all this, not just tooth number 11 ceramic restoration. No, you have to mention in the job order for the lab, Mr. Lab Technician, make this 11 as a monolith ceramic crown, or a 11 tooth, make it a layered ceramic crown. Use a ceramic the coping, and on that you layer the ceramic, right? So advantages of this: aesthetics is excellent, strength is good because it is bonding to the enamel. because the preparation is very less and ceramic bonding to the enamel is very high, say around 90 to 95% success rate if you bond the ceramic to the enamel surface. So any ceramic restoration you go for, look for enamel, be it in a finish line or in the labial or a lingual or a mesial or a distal surface, enamel should be present. Okay. And it can be done in a CAD CAM also. So precision is very good. The only disadvantage what I can think of is technique sensitive, because your lab should be very much precise in matching the shade of the tooth. So where is it indicated? Almost in all the areas: anterior crowns, veneers, posteriors, partial coverage, restoration such as onlay, inlay, tabletops. Contraindications: long span bridges, because the flexural strength of the ceramic itself is not good. Okay, ceramic to ceramic, the connector will break if you give a bridge from starting from 1.1 to 1.5 or 1.6. No, maximum 3 units of ceramic bridge we can give, not more than that, right? Any discolored tooth, you can give ceramic, but make sure you use a opaque core in the inside. Do a monolith and then go for opaque core and then dentin opaque layer and then enamel. If you have a discolored tooth and you write the lab technician, Mr. Lab Technician, do 1.1 ceramic crown, he will not know whether the tooth is discolored or tooth is different shade, or patient is needing a little lighter shade from whatever the tooth shade she has. So mentioning this will help the lab technician and you also to give a good restoration to the patient. How it is fabricated? Lithium disilicate, if it is monolith, it can be done in a heat pressing or milling in the CAD CAM. If it is multi-layered, it can be done in a coping and the porcelain layering technique. So these are the CAD CAM milling blocks. These are the blocks and these are the press blocks and these are the CAD blocks. This is the CAD CAM and this is the press technique. Press technique is nothing but we have been studying in the dental materials, the lost wax technique of metal, restorations. You do a wax up and then you do a you lost wax technique. You use a casting ring and do a investment burnout, and then you inject the metal, melt the metal and inject. The same way, instead of metal, you will be using the ceramic blocks like this. Once we do, we get these kind of restorations, crowns or veneers. This is a sprue. We cut this and then we do a finishing. So I've been telling you about so many materials, PFM and PF, zirconia, layered ceramics and Emax and so many materials. So just remember, if you want to your restorations to be a little more stronger, use a multi-layered restorations, go give a coping and then go ahead with the ceramic layers. Okay. For the posteriors, if the space is less, go ahead with the monolith. Monolith can be given in the anteriors as well, but the ceramic aesthetics will not be that great, right? So you are confused right now, which material to use, where, so many indications, right? I'll give you a small chart so that I'll make it easy for you. In all these kind of restorations, lithium disilicate can be used. Only in 4 unit or more than 4 units, no lithium disilicate, that is no ceramic restoration. Okay, go ahead with the zirconia. All right. So always when you start any restoration in the anterior or in the posterior, always keep the end in mind and then you proceed. You just don't directly jump into the process of crown preparation, impression and sending it to the lab. No, you have to see how the outcome is there, right? For that, what we do something called as a diagnostic wax up, right? Diagnostic wax up, maybe in the anterior only, or the patient wants a full mouth, get the full mouth wax up. Again, it is of two types. One is using a manual method, that is wax method, or you can design it in the digital way, that is CAD CAM. And then you can print this model using a 3D printer. So why should we do a diagnostic wax up, right? Diagnostic wax up, it provides a proper diagnosis for the treatment. You will know how much tooth preparation you need to do, or what kind of inclinations you need to give in the anterior, and you will visualize the treatment outcome, right? And when you do this wax up and show it to the patient, patient will get motivated for the treatment, and you can use this as a guide or an index, and then you can place the same temporaries for the patient, right? So for that, diagnostic wax up is very important. As I was saying, visualize the end of the treatment. You can evaluate the teeth size and shape. If patient wants, imagine the patient has spacing in the anteriors and patient wants to close the spaces. You cannot directly arbitrarily go ahead and fill the spaces. You have to calculate the width and length, and then accordingly you will have to do the wax up, and then tell the guide the lab technician, Mr. Lab Technician, keep the central incisor 10.5 or 11 millimeters, and lateral incisor around 8.5 millimeters, and accordingly you go ahead with the wax up. Only then the lab technician will know what kind of expectation you are having. Imagine the patient is having a wide smile, smile line is very high, gum also visibility is there, and you place a very lengthy central incisor. Definitely the patient will not like, and you cannot go ahead with this kind of a restoration, right? So to have a good treatment in the future, in the course of the treatment, you have to get a wax up done, right? And also write the lab instructions clearly. Lab always has a job order for a reason, because to know what kind of restoration you are needing. So you have to guide the lab technician, sit with him, or you give a call or message him. You have a good rapport with the lab technician, because his work will reflect your treatment. The patient will not see the crown preparation or a veneer preparation, how less you have done, or how nice taper, or how straight it is, how smooth is it. No, patient will see the outcome only. You do a good 100% preparation, all the ideal principles you follow, do a retraction, impression, patient will not appreciate. Patient will appreciate only the crown or a veneer which is cemented, right? So have a good rapport with the lab technician, talk to him, and then guide him to get him into your mindset as what kind of a treatment you or a patient is needing, right? Then again, as I said, you can use this as a putty index, this temporary the wax up. Either you do in a putty consistency of addition silicone or a condensation silicone, or you can use a light body and a putty or a hard body mix for making the index, right? So next is a multi-layered restoration, that is porcelain fused to metal, zirconia, or lithium disilicate. As I was saying, multi-layered, for all these preparations in the multi-layered, yeah, these preparations in the multi-layered will need more tooth reduction. Why? Because these are multi-layered. So you need to give a space for the material to be adapted. Whereas in the monolith restorations, the space needed is less when compared to the multi-layered, right? So in course of time, you are reducing the tooth very less. Okay. So these are the measurements for the tooth preparation in the monolith, whether it's zirconia or the lithium disilicate. Okay. So the maximum preparation will be in the labial side, that is in the middle third to the incisal, that is around 1.2 to 1.5, right? And very less preparation in the lingual, because lingual area will not be seen, and there is no need for you to prepare much, because you need to save the enamel. We have been taught in the school, dental school, that we have to preserve what is there than replace with the new one, right? Divine's dictum. uh, but we have been taught to do a PFM restoration or a PFZ restoration, where we are removing so much of tooth structure and giving back the new restoration. So you might as well don't reduce the tooth structure and give back a material or give back the tooth which will hold very strongly. That is where ceramic restorations are important. Tooth reduction is less and the bonding to the enamel is excellent. So as much enamel is there, the bonding will be stronger, right? So coming to tooth preparation, only the labial surface, as we know the anatomy of the tooth, enamel is thick in the incisal edge and in the labial middle third. Palatal surface, very 0.5 to 0.8. Incisal edge, little more preparation, that is around 2 millimeters, unless the patient is having an treated tooth. Okay, so if a patient is having a treated tooth, there is no need to prepare so much of the incisal edge. Already the incisal enamel is gone. There's some issue with the screen. Okay. Yes. So for the preparation, which are the burrs you will use? There are only two types of burrs you will be using. You have learned so many of kind of a burrs when you go for any conference or you come across in the dental. I don't know if there is some issue with the screen sharing here. Uh, I'll just pause the screen share and then come back to you again. Excuse me for this. Yes. Yeah. As I was saying, these are the tooth preparation measurements to be followed for ceramic restorations. And then you will place the finish line during the preparation, right? Which are the finish lines you will place? We have been learned so many finish lines in our dental school: shoulder, chamfer, knife edge, feather edge, a rounded radial shoulder, radial chamfer, right? Deep chamfer. So all these kind of restoration, finish line. I want you to just remember only two. That is modification of this shoulder. That is a modified shoulder, and modification of chamfer, that is deep chamfer. So only these two you will remember and only these two you will apply it in the patient during the preparation. Modified shoulder is nothing but rounded shoulder. For that, you will use a specific kind of a burr which has flattened top and rounded edges like this. With not a random burr, you will get this kind of a finish line. No, you have to use this specific burr, only then you will get this kind of a finished line. Modified shoulder and a deep chamfer or a round taper will have a dome shaped tip here, right? So only these kind of burrs you will use, right? See this shoulder with a rounded edge like this will have a smooth, free flowing enamel like this, right? And with the chamfer, you will be having a sloping kind of a preparation that is more than 90 degrees, right? Only these two preparations you will use. And during the tooth preparation, be it anterior or posterior, always use a burr in the straight, perpendicular to the parallel to the tooth surface, because the burr is already having a inbuilt taper to it. So use it straight so that we'll get a taper. Over tapered crowns will have a least retention, right? So, so which are the preparations and which are the finish lines you will give? Only when you are giving a PFM, you will have a modified shoulder in the proximal or a buccal surface. Rest all the preparation which you do in your practice, deep chamfer is a finish line which you will prefer because this will preserve the tooth surface. See this? See this? If you are going ahead with the modified shoulder, you have to finish from here till here, right? Like this. Instead of that, you can give a deep chamfer, but still you can preserve the tooth structure here. All right. Am I clear? Am I going fast? All right then. So next, you might ask me, which are the burrs I need to use? You have noticed the grids or the color around the burrs, the green one, a red or a yellow or a blue. So anything green or blue is for gross preparation because the grid size of this diamond blank is more. Red is for finishing of the preparation and yellow is for polishing of the preparation. You are not supposed to prepare with this yellow burr, yellow ring burr, right? So keep it simple. Just green or blue, one set, red and then yellow, right? Don't keep all the colors, white or blue, only one set, anyone you follow. So make it a habit that keep a burr kit separately, blue, green or yellow like this in one for anteriors, so that your nurse or assistant will know that if you have anterior tooth preparation, she will take out or he will take out only this kind of a burr set, not the whole burr kit for you. Or keep it as an assorted one, blue, yellow, green with different shapes, sizes, so that this burr kit is for anterior tooth preparation, right? And this is for the posterior one. So when you're giving a ceramic restoration, you will never stop. When you're giving a zirconia preparation, zirconia, you will stop at red colored burr, right? Because zirconia will not bond. It will lute mechanically with the tooth surface. The crown zirconia will lute mechanically to the tooth surface. So you don't want a finished or a polished surface because the cement will not stay there. You might have come across zirconia crowns dislodging very often. That is because you have very much polished the tooth surface with the yellow burr, and that's the reason there is no retention. This is one of the reason. Okay, so when you're going ahead with the ceramic restorations, be it veneer, crown, inlay, onlay, anything is it, you have to use a green, red, and yellow, and then go ahead with the finishing extra polish also with the polishing disc because the ceramic is bonding to the enamel or a tooth surface. So you need to have a very smooth surface so that it is chemically bonded well, right? So enamel is there, the bonding is high for the ceramic. So next part of the lecture, we will learn something new and exciting and little bit of imagination, and you will know many things, and you will learn new things, and it will provoke your thinking. And once you go back tomorrow, you will explore this area of aesthetic prosthodontics, right? So this is the world of biomimetic dentistry. You have been heard this term now, and with this, you are preserving the tooth structure that is very less preparation, minimize, it will minimize the unnecessary preparation which we used to do, right? Tooth structure is preserved, adhesion is maximum in the enamel, hence the structural integrity is good, and use of biomimetic material and techniques, that is nothing but using the lithium disilicate ceramic. We have come from a time where we used to prepare around 1.5 millimeters overall like this. Then we came to zirconia, started reducing less. Then we came to veneers using the ceramic lithium disilicate 0.5. Now we are following something biomimetic dentistry where we reduce only 0.1, or without preparation, we are placing the ceramic veneers for the smile designing cases. So now do you feel that these many days you are practicing this kind of a dentistry where you are sacrificing so much of tooth structure, right? Because you were choosing PFM restorations or the zirconia restorations. So when you go ahead with the ceramic restorations, automatically you will reduce the tooth structure to save the enamel so that the bonding is good for the ceramic, right? One such treatment is veneers, that is ceramic veneers. You'll use this for the smile designing or any anterior restorations. So how do you prepare for the crown as such, which I told you in the past, you will have finish line, which will prepare deep chamfer or modified shoulder. But in the veneers, you will have different kind of a finish lines. Which are those? One is the feather edge design, which is very minimum preparation from cervical part to the incisal part. Then you will give a palatal chamfer design where you will knock off the incisal edge. Prepare here because we need to elongate this tooth with a good translucency and incisal anatomy. Or the tooth already is attreated, you can go ahead with this palatal wrap kind of a design to give a good structural integrity for the veneer, right? So as I was saying, you see the preparation here. This is already a prepared tooth for a ceramic veneer. Such minimum preparation here without breaking even the contact, because only the aesthetic demand of the patient was there to change the color and shape of the tooth, not the whole tooth. You see, this is a crown preparation here done for a root canal treated tooth. So when a patient comes to you actually this patient came to replace this crown after the root canal. Then I gave the patient the option. See, if you want to change the color of the tooth or a shape, you can do right now, because once I do this crown again, if you are later in your life, you want to change again, I have to change this crown. Then the patient was asking, doctor, do I look good in the smile designing like this with the veneers and crowns, new ones? I said, yes, definitely yes. Then how do I look? I suggested her to do a smile designing with a digital smile design, took the photograph, designed it in the software ExoCAD, and got a 3D printed model, showed it to her, and she liked it. Yeah, yes, doctor, yes, definitely we'll go ahead with this. It comes with the cost, yes. It comes with the extra care, yes, definitely. Always bear in mind when you are giving ceramic restorations in anterior veneers, as such, tell the patient that patient has to take care a little bit extra, because these are the delicate ones, just like our lenses which we use on our eyes, right? So this is the one of the preparation, very minimum preparation. This was less than a millimeter preparation. You can see this here, just to make space for the roughen the enamel and then place the veneers on the top. If you want to go and change the complete shape of the tooth with maybe a mild crowding case, you can go ahead with breaking the contacts and then preparing the veneers. All in all, 0.5 to 0.7 millimeters. And in the margin, it is less than that, because the enamel is less in the margin, as we know is in the anatomy. Incisal edge, prepare a little more so that the light will pass through this area, and then it will give a good aesthetic look for the patient. So the lab-made indirect restoration is the most stress-reducing technique, as there is zero volume shrinkage in the during the complete setting of the material, right? So yes, it comes with the cost for sure. It is not affordable for everyone, but that doesn't stop us from doing this in our clinic. We have to give these options to the patient, because many of the patient doesn't know this kind of treatment exists, or what will be their look after doing this. So you have to spend a little more time and energy explaining to the patient, do a little bit extra from your side, even though the patient is not interested. Maybe you think that the patient might convert into a smile designing anterior. Put a little effort, make an impression, send it for the wax up, get the putty index. Just tell the patient, I'll just try this new smile of yours. This is from my side. It doesn't cost much for us for a wax up, right? So, and do it for no cost and show the patient the outcome, how it is. Patient might like and go ahead for this kind of a treatment, right? So this is how you get into the practice of aesthetics, right? So once you do the preparation, finish line you have placed, then next comes the impression technique. For that, you have to follow something called as soft tissue management, right? You see this? As of now, I spoke about the materials, preparations, right? You know how to prepare. Now we need to manage the soft tissue. Then we will do the impression, shade selection, temporization, and cementation. Okay. So this is the next part of the lecture. So let's concentrate on this soft tissue management. So before I jump directly into the topic of this soft tissue management, let me take a minute and make you understand why we should manage this soft tissue. Because to get a good impression, you don't want your impressions to be like this when you send back to the lab, right? See these? These are not good impressions. And when you give this kind of impressions to your lab technician will not agree and you will not do such a good job because the impression is only not good. And we as a dentist have little bit of ego when a lab technician says us, doc, make a new impression for me because the impression is not good. We take it to our hearts and said, no, you go ahead and I will look after how it is in the chair side, right? This is what we have the mindset. How can a lab technician guide us clinically what to do and what not to do, right? But no, we'll spend a little more time on impression making and do a good retraction, either with retraction cords or with the retraction paste. So the mechanical retraction is through the retraction cords, right? Which are the cords? Twisted, braided, or knitted cords, right? Twisted is not much used because these are very hard kind of cords, which when you place in the sulcus, it will jump back. Braided were the one next which were evoluted from the twisted. These are the ones which are which can be used, but when you use a retraction cord, it will the retraction cord will come in between these braided cords, and then it will get stuck there. So that's why the knitted cords were introduced. These are nothing but thousands of small threads which are interlocked together, right, to form this kind of a knitted one. So what is advantage of using this one is it when you press this with the cord with the cord packer, it will compress, and definitely you will be using the retraction liquid, that is aluminum chloride or a local anesthetic agent. When the fluid is acting on this one and when you compress during the packing of this into the sulcus, when you leave it for 2 or 3 minutes, it will swell back. During this process of swelling, it will open the sulcus, right? And then you can go ahead with the making the impression, right? And even though the burr gets stuck in this, the cord will not interlock with the high speed burr which is turning. So how can we use these cords? It can be used in a single cord technique or in a double cord technique, right? When you use this single cord is nothing but only one cord using. When you have a thin type of mucosa, right? The mucosa, this attached gingiva here is very thin. You will use only single cord technique, or the sulcus is very shallow, very small sulcus here. You will use a single cord technique. See this photograph in the left here is a single cord technique. Single cord is used, and after that you will use a second cord. Right? Always remember, when you're using this two cord technique, only the second cord should be visible to you. The first cord should be completely into the sulcus. Or if you are using a single cord, use a thicker cord so that it will go completely into the sulcus. Right? You should see the finish line when you do a retraction. If you are not seeing the finished line during the retraction, before the impression making, then it will not be recorded in your impression. When you are not seeing the finish line, how come a lab technician will see? No. Okay, so make sure the finish line is visible during the impression making. Right? That's the cord packer which I am using. See the angulation here. I'm not going perpendicularly to the sulcus. I am giving a notch. I'm giving a angulation and pressing into the sulcus. Right? See the angulation. I am targeting the area where the cervical constriction of the tooth is there. Right? We have been learned in the dental anatomy, the tooth labial surface, and after that there will be a cervical constriction before the root starts. So that is the area where you will pack the retraction cord, because there till there the finish line is there. Okay, and you will place the finish line for the veneers or in the anterior equigingival or supragingival, not subgingival at all. Subgingival finish lines are old fashioned and they will not be so hygienic, and the patient will come back with the gingival inflammation. So equigingival or supragingival. All right. So when you are using first cord, see the finish line is here. First cord is completely into the sulcus and the finish line is seen. And when you are using a second cord on the top, I don't mind the second cord is seen in the sulcus. That is fine for me, right? Because the first cord is retracting. Okay, see this double cord here. First cord is giving a vertical compression to the gums, to the sulcus. The second cord is giving a horizontal separation from the tooth surface. Okay, the gums swell up horizontally, right? So the second cord will give a horizontal retraction, and we use very mild pressure. When we use this, when you give the supragingival finish line, automatically you are saving this cervical constriction here. Can you see this? This is the place where the cord will sit. If you go more deep, the cervical constriction is lost and your cord will not place properly, right? Use very gentle pressure. Okay, do not put more pressure like the more force and damage the attachment. Once the junction epithelium or a sulcus is damaged, it will not return back to the same place. We all know that. Again, there will be a bleeding. We have to control the bleeding. It will be reflected in your impression and the process of errors continues. Right? So use very gentle pressure. Use single cord or a double cord. Single cord you will use where the thin biotype of gingiva is there, and the double cord you will use where the thick kind of a gingiva is there. And also the sulcus depth. Sulcus depth is very low, shallow. You will use single cord. If the sulcus depth is deep, you will use double cord. How will you check this? Take a marked periodontal probe, that is a black shaded one and one non-shaded marking. Put it in the sulcus and then check whether the shadow of this periodontal probe, marked periodontal probe, black one, is visible through the gum. If it is visible, it means the thin biotype. You will use a single cord. So you have to do this before the preparation even starts, not during the preparation. Okay, this is all comes with during the treatment planning, right? And after that, you will tell the assistant that I'll be using this single cord technique. So you give me number 2 or number 3 of cord and put a liquid and soak it and keep it ready before the preparation starts. That's how you have to train your assistant also. Or if you do not want to use this mechanical retraction cords, you can use the retraction paste. Okay, so it is nothing, just kind of a paste which comes in a capsules like this. And This is from the 3M company retraction astringent paste, right? You have to load the capsule. Dry the area. Do not over dry and um, make it completely dry. Again, the clot which is formed might dislodge, and again the bleeding points might start, right? That's how retraction paste is used. This retraction paste is not only for the retraction paste, it's also an astringent. Nothing but if you have a bleeding point or a bleeding area there, you can use this retraction paste. You can use it as a combination also. Single cord you use, double cord, during that stage you might have a little bit of bleeding, place some retraction paste. Or after the single cord, you can use a paste around this also, right? You can save the second cord. And yeah, what I forgot to tell you is use this. If you're using a single cord, two cord technique, in a two cord technique, use the first cord thinner one so that it is completely into the sulcus. The second cord which you use will be a little thicker than the first one. All right, not using the vice versa. And then you go ahead with the impression material. Which material you'll use? No, alginate. Alginate is only for the diagnostic cast or the treatment planning, not for the final impression, because it is not stable. During the process of manipulation or in the placement or in the taking out, it might tear, it might dislodge from the tray. So this is the first step where you are recording the impression, and you have, this is the negative replica, and the model cast will be ready. On this, the patient, the lab technician will be working on. So you should have as much accurate impression as possible, right? So you'll use addition silicone, that is polyvinyl siloxane. Okay. So there are two techniques. First one, you'll use, okay, polyvinyl siloxane, we all know that it will come in four consistencies. First one is the putty consistency, hard, medium, and light. Okay. So you can mix and match these consistencies to make a impression. Which are the two techniques? One is the single consistency technique, that is using a single step technique, that is using a putty as a base, and you will put light body on the top of the putty, and then you place in the patient's mouth and take it out. That is single stage technique. There's two stage technique where you will put a putty and put a barrier on the top. This is nothing but a transparent sheet or a RVG sheet, which we use for the X-ray, or the intraoral camera sheet, which we can use, or the lab, you can ask the lab technician to give the sheet which you use for the dentures during the packing process. So it's a thin plastic sheet. You can use this and make the impressions first. So this will act as a tray material. The putty will act as a tray material. You can remove all the excess from here, and after that you will pour the light body on this area here, and then put in the patient's mouth and then take out. That is a two-stage technique. I prefer this two-stage. Why? Because you see this slide here, my tooth preparation, my margins here are recorded by the light body. I want this. You can see this finish line here, right? My material here has flown beyond the finish line. It has recorded the sulcus also. This is very good. When my cast is poured, my lab technician is going to be very happy with me because the finish line is seen so clearly. If I use a single stage technique, putty is recording the tooth surface here, right? Putty is not that accurate as light body, right? So always use a two-stage technique. What I generally do, this is kind of a tip for you. Even before I start the preparation, I make this impression and keep it ready aside, right? So that the tooth preparation, the tooth which I will be taking the impression for, maybe 1 or 2 crown, will have a putty base here. And when I prepare and put a light body on top, whole of my tooth is completely covered in the light body. That is, it is recorded very nicely, all the surfaces. All right. So that's the first stage technique of the impression. Yes, there is the tooth is not recorded. We want this as a tray material only. Sorry. Yes. Yeah. This was the case which we saw in the previous slides. This is a combination of veneer and crowns. Single chord. After the preparation, double chord. The time you will remove the second chord from the patient's mouth, immediately you will be putting the light body around so that the gingiva will not compress. In the same time, your technician, your assistant should put the light body in the on the tray, and you have to blow the light body so that it is properly adapted to the tooth surface. See, the tray with the light body is now going inside, and stop. Do not go on compressing or putting a pressure on the till the material is set. If you do that, the light body is completely pressing inside and going into the sulcus. That's the first cord which was there into the sulcus. You might remove that or you can keep that also. So after that, you have to make the bite registration, select the shade along with the temporaries. That is the impression. You see the margins here. You can see you have to see always two margins, be it anterior or posterior impressions. First margin is the finish line and the second margin is the sulcus. So it means that my material has flown beyond the finish line. This is what we want. See this? Can you appreciate? We want this kind of impression. Your lab technician will be very happy. And examine your impression immediately once it's out of the mouth. Why? See these micro tears here. See this? This cannot be seen unless you use loops. Loops are mandatory for dentistry. I'm not saying only ceramic restoration, anterior or posterior or implant, whatever you do. Any treatment you do in your practice, loops has to be used. Make it a habit. If you're not having one, gift yourself a loop on your birthday. Yes, why not? We are gifting ourselves a new mobile. We buy a new jacket, new shoes. We go on a trip. Invest on a loop that will improve your practice, right? And to start with, 2.5x is okay. We can easily do scalings, extraction, crown preparations, root canals also. Once you are used to 2.5, go ahead with 3.5 or 4, right? So that will improve your quality of the work. That will make you stand out from your colleague dentist, right? See, that's the difference between a single stage and a double stage impression. I want my impression to be covered into light body because light body flows everywhere, and I don't want my light body into the palate or in the sulcus like this, right? This is of no use. I want my light body on the tooth surface, right? I might as well not flow the light body here. I am not using this area at all. Got it? And once you make the impression, this is the other tip. Do not ask the patient to close. You have to support with your fingers. Okay. See, once the patient bites here, the tray is tilted. For you, the impression might be very good, but you don't know that the tray is tilted. Cast will be poured, and then there'll be the crown or veneer or restoration will fit on the cast, but it will not fit on the patient. Who is at the fault? The lab technician. They don't do good work, right? So from your side, you have to give your best so that your lab technician can return back to you. Okay. So after this, you will be doing bite registration, which with what material? No modeling wax, no red wax. Red wax is for the denture work. Okay, you have to use rubber-based bite registration paste. Why? Because your bite registration paste should be rigid. It should not bend. It should not mold itself. Okay, it can break, no problem with it, but it should not bend. If it bends, it means there is distortion. So use this bite registration paste of addition silicone, PVS based. There's a video showing how do you pack the cord. First cord is still inside. You can go ahead with the scanning if you want to follow digital protocol instead of impression. And when you are using the retraction cords, you can use aluminum chloride, ferric sulfate, or local anesthetic agent, either of these three. But what I prefer is aluminum chloride. Why? Because using ferric sulfate will make the clot darker, or a brownish or a blackish clot will be formed, and it will discolor the tooth when you are making the impressions, or it might form a thin layer, or if you're using this liquid during the cementation, this will discolor the tooth or the veneer itself. So using the aluminum chloride is safe, and it will do the job of retracting or astringent effect in the during the retraction. Okay. So next comes the shade selection. When will you select the shade? You have to select the shade before the start of the preparation, after preparation, and after placing the temperatures. Take the photographs, document it, keep it with you, send it to the lab technician. Mr. Lab Technician, this was the shade before, after I prepared, this was the shade, and after the temporary, this is the shade. So the lab technician will know how, what shade the core is there. Okay, after the preparation, either core is the same as the tooth color or the core is darker. If you have a darker core, right? If you have a darker core, you cannot use translucent ceramic. The lab technician will not know whether the core is dark or not. So you have to you have to click a photograph, select the shade and keep it. Okay. To select the shade of the core, use this dye course. Okay, natural dye material. This is a different shade guide for the core itself, or you might as well use something which we regularly use. There is a composite shade guide. Composite shade guide will have a little darker shade tabs, right? After the temporaries, give the lab technician choices of three. and to the patient also when you choose. The patient should know one lighter and one darker. This is the selected one. Why? Because the patient will can appreciate the color more better, and do it in a daytime or in a natural sunlight, or nowadays the clinic lights will have are coming in the same intensity of the daylight, that is around 5500 Kelvin to 6000 Kelvin. So when you're choosing the clinic lighting, you can choose a lighting which has around 5000 to 6000 Kelvin range, so that you don't need to select the shade in the daytime. This will give you a natural day effect, right? So many of the companies of these lights also have this. Fine. So then next again, you remember the temporary, the wax up which we did? We can use the same one for the temporization. But before temporization, make sure you have to do some kind of a etching. Okay, spot etch it is called. Not the whole surface, only a part of that tooth should be etched. Bond that tooth, and then use a temporary material into that index, put it in patient's mouth, take it out, polish it. Polishing has to be done after the temporaries are placed. Without the polish, do not send back the patient. It will take around 1 week or 10 days or 2 weeks for the restorations to come back from the lab. If you do not polish, the gum will be inflamed, and during the cementation, the gum will be bleeding, and it is very difficult for you to control the bleeding from the inflamed gums, and it might interfere in the cementation protocol, right? How will you polish? The yellow burr or the polishing discs like this, right? With what material you will temporize? You will do a temporization with PMMA, bisacryl. Okay, bisacryl material you can do the any company, and every company comes with the different shades, A1, A2, or even the bleach shade is available. Okay, this is the self-curing material. There are two techniques again. After the temporaries, take out the index. This is the index, and you take out, and then you will polish it. You will not take out the temporaries from the tooth. The other technique is there where you will take out the temporaries from the tooth. Right? They are very thin shells of veneers. And then you will use cement to loot this. But again, this is very thin. The cement shade might be seen throughout, right? There's a material called temposil, which comes in white or opaque dentine shade, where it is little yellowish and gives a natural look to the tooth, right? This is the same case which I'm showing it to you. When you're using this material, make sure the tip is always into the material. Do not lift it outside. When you lift out and put it back again, the air entrapment will be there. Okay. This is the immediate temporary. Before the preparation, I just made a temporary, I made the index with the putty and light body. I'm placing back the same tooth shape with the patient was having, and I'll modify a little bit of this with the flowable composite and to get a good shape to the patient. Right? That was about the manual way of doing it. Let's go a little bit extra. Why this webinar was there? Why we chose this topic was to include this digital smile design. It itself is a very big topic, and we conduct this back in India. We conduct a 2 days workshop for the smile design. I'm just telling you overview of this. How does the process of the digital smile design goes? If you can concentrate here, pre-op model will be there. You will send the photographs to the lab technician or any exocad person who does the smile designing. He will design the smile. He will design the veneers or crowns in digitally, and it will be printed in the 3D printed model. And that index you will make, place it in the patient's mouth, prepare the tooth, and then again, no need of temporaries. If the smile designing is confirmed before the veneers are readily available, you will prepare and place back the veneers immediately. Okay, so this is the short video how I designed this smile for this patient. This was done in exocad. When we learn this exocad, you can do the smile designing or a crown designing, prosthetic designing by yourself, so that you will know how what kind of a contour you can give. I know it's a lab technician job, but it's never that now. Before 5 years or 10 years, it was a lab technician job, but you as a dentist should know how to design this and give a custom smile for the patient. Yes, this will need a new skill, definitely, and it will take some time from you. But once you learn this, you will really love it. You'll spend more time on this, exploring the things. See the way it is contoured to that minute level. That is corrections of the occlusion. Occlusion plays a very important role, because even though you send this for a lab technician, please visit the lab technician and tell him to show what he is doing, or send him to tell him to send you a design. At least you can have a look at it and you can tell the corrections for him. Have a good rapport with the lab technicians. Then after doing this, you can import the patient's smile, mark the reference points, align it to the scan, select the smile area, select the tooth, midline, smile curve, and tooth contours can be manipulated. Libraries are available. There are different libraries of the tooth shape. Yes, got an idea on this. So after this impression, you will have to communicate with the lab. You will not just write 112113 ceramic crown. No, you will have to write monolith or multi-layered, which material to be used, zirconia, lithium disilicate, whether it's a how to do a coping, zirconia milling or ceramic milling. How is a lithium disilicate core? It should be done in a press technique, CAD technique, layer technique. Shade of the tooth and shade of the core, which kind of a translucency to be used. If it is darker core, darker tooth, go for low translucency. This ELT is low translucency, medium and high translucency, or something called as opaque is also there. So ask the lab technician to use a opaque coping core. On that, let him layer the final shade. Okay. So any restorations, ceramic can be used, as I said before. So very thin veneers to the 3-unit posterior crowns also ceramic can be used. Okay, Emax CAD or Emax press, right? I have an in-house lab that is a centering machine here. This is I have two systems, Sirona and ExoCAD lately. Before I used to use the Sirona. So this is a Ceramil, and this is a program mill from the IOCLAR. This is a new one which does dry and wet milling. I have a 3D printer in-house. I can print the surgical guides or the veneer temporaries also. Okay, so go visit the lab and see how your restorations are done. Lab when you give little more time in the lab technician also appreciates your job. I think there is some, yeah. That's the lithium disilicate blank. That's how a CAD CAM full contoured crown is prepared. Crown or bridge is prepared. Within 15 to 20 minutes, full contoured crowns or bridges can be done. After that, a glazing will take around 15-20 minutes. So within an hour, if you have a chair side milling machine, or you are attached to any of the labs, maybe you give an impression in the morning, and by evening the restorations are ready. So you can set up your practice like that. One day dentistry. Patient comes in the morning, roams around the IDIS, and in the evening you'll place the crowns. Right? So this is the case of veneer. You see the translucency, how it is done here to natural, or the labial contours, veneers, very thin ones. So temporary is done. You'll send back the lab to get the restorations, veneers or crowns. Patient comes back to you like this. So now your job is to take out the temporaries. Always protect the gums before taking the temporaries out. Either you can use any cement instrument, plastic cement filling instrument to knock off the veneer or a crown, or you can section it with the red ring burr, so that your preparation is not harmed inside. And then you will use any instrument and give a nick like this. The temporaries will break off and you can take it out. Okay. So after the temporaries you take out, you have to polish it with non-fluoridated Profi paste, not the fluoridated one, because it will interfere in the cementation process. Okay, so now you get a lithium disilicate, that is ceramic restoration. You have two things to do. One is to prepare the ceramic crown or a veneer, and the other one is to prepare the tooth surface. There are two things you have to do. So how will you prepare the ceramic or a veneer or a crown? After the trine, you use after taking out the temporaries, you trine the restoration, be it a crown or veneer. Show the patient, you see how it is. If the patient is going ahead with the cementation and you are agreeing with what the lab has done. So next step is cleaning the restoration interior surface with the IO clean. IO clean is nothing but a non-alcoholic agent where it will remove all the saliva particles which is adhered, or any impurities which are adhered in the ceramic surface, where it might interfere in the bonding of the ceramic to the enamel. Okay, so the cleaning this is very important. Again, the study shows it is needed or it is not needed, but I follow this. I'm not publicizing this brand, but this is a readily available cleaning agent for the ceramic. And then you will use porcelain etch, not the etchant which we use for the composite. No, this is separate ceramic etchant which we get. Okay, this is hydrofluoric acid. Okay, that is hydrophosphoric acid that we use in the composite. So after using this ceramic etchant, you will wash and dry. After this, you will use something called a silane agent. Apply the thin layer of silane agent and dry the surface. Do not wash it. Right? Okay, this is one way of preparing the veneer or a crown. right? So first you will use this IO-clean, after that you will use this etchant, and after that you will use a silane agent. There is something called as monobond etchant prime, where the etchant and silane agent comes with single liquid like this. So you will save some time and you can directly go ahead with the monobond etchant prime after using this IO clean instead of going for ceramic etchant and silane. Okay, there are two ways of doing it, right? So once you use this one, since it is fluorescent green or bluish color like this turquoise, so make sure you wash it immediately after 20 seconds. Do not dry it more because this color will adhere to the veneer and it will not go that easily. Okay, so your surfaces are ready now for the bonding. Okay, so before that, always do a try-in, show the patient, take the photograph, show the patient. How will you try-in? You will use a try-in paste. Every veneer cement, okay, every resin cement will have a try-in paste. This is only for placing the restoration on the patient's mouth. It will not bond. Okay, and it comes in different shades also. See this here, this is ioclar. This comes in light plus and light. That is around BL3 and A1 shade. Okay, and the translucency also varies. Imagine the patient wants in A1 shade. There is A1 shade trying paste which we can use and show the patient, and you can have a look. Okay, so once the train is done, your veneers are ready. Next comes the rubber dam isolation. Rubber dam isolation is mandatory if you are practicing ceramic restorations. Rubber dam isolation is part and parcel of this aesthetic dentistry, right? You can isolate the surfaces and work in a fluid-free environment. And you can be very much sure about the proper fit of the veneer or a crown. Okay. If you have cemented one surface and then going ahead with the next one, protect this with the Teflon. And then you can go ahead with the next tooth cementation. Okay, the other way of doing it, again using the clamp and tying it with the floss so that you can see the margin very clearly. Of course, it will need again new set of skills, and again local anesthesia has to be given. So practice it on the models or do a training where they teach all this for the smile designings also. And then again, not individual tooth, you want to do a segment of isolation, you can also do this kind of a retraction also. I mean the isolation with the rubber dam. All the teeth are isolated all together. Okay, be it an upper teeth or a lower. Okay, if it is subgingival also, you have to make sure the visible margins are there before the cementation. Okay, so after the cementation, you'll use a cement and you will cement and use this oxygen inhibiting agent, that is glycerin or any non oil based gel, because oil based gel will adhere to the veneer or the cement. So non oil based gels you can use. Okay, so if you are using you are doing, go ahead with the bridge cases. Uh, Cover this with the Teflon and then do the cementation. And after that, tear this Teflon, do an interdental flossing with this Teflon and take it out so that you can be made sure that the cement is not remaining inside. Okay, so that's the cemented surface, bonded surface, sorry. There's a etchant. Do a tack cure first. Take out all the excess with the floss or with the 12 number BP blade. Then after that, go ahead with the final curing. Do not cure completely 30 seconds. First, just do a tack cure. That is for around 3 seconds. You are using a light cured resin cement here. Okay. It comes with the kit like this. This is from the IOCLAR. This from the 3M. So whichever you are comfortable with, you can go ahead. This is the case where all the set of veneers are there. So you can use a single shade of the tooth unless there is any core, darker core. Okay, so light cure cement, resin based light cure cement you can use. If you have a combination of such cases, crown and veneer together, onlays together, again you have to use a dual cured resin cement for the cementation. Again, it comes with different shades, opaque, A2 or A1 shade, light shade like this here. So whichever shade is matching to the patient. If it is darker core, use a opaque one. If it is lighter, use A2 or A1 also. Okay, again, it depends on the how the tooth surface is there. You're not done yet. You have to check the occlusion before you leave the patient. Occlusion is very important. You have struggled so hard from the start till reaching the cementation, and then you have occlusal interference. It means you are doing something wrong, right? So, which articulating papers thickness will use? There are two ways of doing this. Either use a single articulating paper of around 40 microns, or you want to minimize this more, become more precise, use 80 microns first, and after that use a 8 microns or a 12 microns. Okay, so there are two ways of doing this. I follow, if I'm doing a whole set of smile designing, 40 microns is well and good for me. Only one color and one articulating paper. But if I'm going with the posterior, I'll have a different protocol where I use two different colors and two different thickness of the articulating paper. Okay. When will you check the articulating marks? Before the start of the procedure. You have to give back the patient the same occlusion what the patient has come to you. Okay, you don't want to change the whole scheme of occlusion for just one single crown. You have been noticed, the patient will tell, I am not feeling good in the crown, only the crown is touching first and then other tooth during the cementation, and we give him a relief saying that no, this is just a new thing in your mouth. And but when we have this crown, thankfully I don't have any crown. I don't want to have to. I don't want. I'm really scared to sit on the chair. But that feeling of the crown, extra something extra on the tooth, something for the patient is really, it's a big thing for him. But we as a dentist try to neglect that, and so for that reason, choose a good lab which uses a good articulator. Again, I'm not go deep into that. It's again a different topic. Uh, Articulating paper marks first you check before the start of the procedure. And which are the ideal marks? See, these are the ideal marks for the occlusion in the anterior. The posterior, these are the ideal. Two in the functional cusp in the molar and the mesial marginal ridge of the maxillary. In the mandibular, functional cusp, that is a buccal cusp, and one in the central fossa and in the distal marginal ridge. So these are the ideal occlusal points. You either keep this or whatever the patient is having. How will you know what the patient is having? Before the start of the procedure, mark it, take the photograph, send it to the lab technician so that he'll also articulate and do the restoration according to what the markings the patient has. And when you are doing the veneers, make sure the lower tooth is not touching the veneer directly in the palatal area. Okay, direct touching like this will chip off the ceramic, and same in the posterior also. So give a good ideal overjet and overbite. How will you know this? You will know when you do a diagnostic wax up and transfer that to the patient before the procedure, right? So how will you maintain this? Do not use ultrasonic scaler on the crown. Maybe during the start of the practice or something, it is my experience. One incident happened. There is a calculus, or there is a recession, and then there was a calculus on the tooth. And I went on and took out the calculus from the sulcus, and I touched the crown. There's a black mark. To take out that black mark, I went on scratching the ceramic crown, and there was so big black mark there. So I could see my signature there. So it was something which I didn't know during the start of the practice. So never use ultrasonic scaler tip on the ceramic surface, be it a PFM crown, PFZ crown, or a ceramic crown. Only profi polishing, and use a hand scaler. Okay, if you feel that you have any excess cement or the calculus around the veneer or a ceramic. Around the ceramic acid, there will be no calculus until you have an open margin or the recession. Ceramic and gingiva biocompatibility is very good. So if you want to see that fleck of the calculus or extra cement, do a retraction first. Okay, visibly see that area and then take out that fleck of the extra cement or the calculus, and always polish with the rubber cup with the polishing paste. This is the ceramic polish paste. Do not use a regular polishing paste because the particles are very thicker, bigger. So when you do use that polishing agent, regular polishing agent, what we use after the scaling on the ceramic, it will scratch the ceramic and it will discolor more. Always use this ceramic polish paste, whichever company it has. And any anterior restorations, full set of sorry, full set of anterior crowns or veneers you are giving, give a hard acrylic splint. Hard acrylic splint, so that the ceramic is saved from the occlusal scheme, with the new occlusal scheme which you have given. Okay. I know indirect restorations are challenging, and smile designing ceramic restorations are more challenging. There are solutions for that. What is the solution? You should plan the case. Plan the case or plan the case. Okay. And not just planning. You have to practice, practice, and practice. What I generally say, don't practice until you get it right. Practice until you don't get it wrong. Right? So you make a flow chart of whatever the things to be done for that one single restoration. Keep the things ready, materials ready, rehearse with your assistant, do a mock drill where the patient is there and you are doing a patient in a real situation. Don't get interrupted. So that's what practice makes us do a very good job, and you will know your flaws, and documentation is very important. Every stage take photograph. We have mobile phones, not in a DSLR, at least mobile phones. Take photographs, go back and see what you have done in your day's practice, and you will see the change as and when you go on day to day, documenting it and correcting it, and you'll see the mistakes what you have done, right? So there's a small video to show that when you want something genuinely, whole universe will conspire against you for you to go ahead and reach that goal, right? So keep that thing in your mind that you want to have a good, what do you say, have a good set of practice, kind of a stand out of the crowd with your neighboring dentist. Spend some more time in your clinic or the lab, and definitely you will achieve what you need. And as I said before, let today be the start of something new. I hope I have made some difference in your thinking regarding the practice and the ceramic restorations as such. So, any doubts or clarifications, or you want me to have some discussion with you, these are my contact areas, and I would definitely want to thank entire community of this EDPA. I think we have around 100 plus participants staying for 1.5 to 2 hours listening to this elaborated lecture is not a small thing. I know attention span is not more than 40 minutes. I tried to mix and match the videos, photographs, and try to make as much interesting as possible. And as such, this topic was a very huge one. We tried to concise it as smaller as possible, but covering all other topics. So special thanks to EDPA President Dr. Meron Dr. Addis, the treasurer, Dr. Esdin, the CPD accreditor, director, Dr. Mandia, CPD provider, and who helped me with this Ethiopian celebrity information. So I could connect with him for this information. And most important, Dr. Addis, moderator of this session. I guess there are some issue with the audio, and Dr. Jebin, who has been support for all this, the Cochin Implant Center. Although we are there for the implants, and we do have a sessions for prosthodontics and smile designing as well. So thank you, Dr. Jebin, for that. And not to forget, my wife, Dr. Sabha, who is also a prosthodontist and implantologist. I go back home and we discuss cases, even though during the sleep, I mean, in between the sleep and getting up, we have this kind of a discussion of materials or which lab and lab cases has come or not. So she has been my pillar of support and backbone, who has helped me in gathering this kind of a content for this webinar. And thank you once again for everyone who is around 100 plus year audience for joining here and sparing your weekend Sunday evening. And I hope I have made some difference in your thinking. Thank you, one and all. And any doubts or clarification, the chat section is there. You can type down the doubts or clarification. I'll be more than happy to answer that.